Hello, today we're discussing a systematic guide to conduction blocks. There are a couple of foundational clues we should start with. The first is the cardiac axis, which way is the electricity flowing in the heart. And for this, we need to examine a couple of leads. One way of assessing this is to assess whether lead 1 is positive and if AVF is positive. If both of these are positive, then the axis is normal, roughly. Or you can find the lead with the isoelectric signal and look at the lead at right angles to that to see if that's positive or negative. So, if you look at this zoomed up view, the normal axis is from 0 to 90, left axis minus 90 to plus or minus 180, right axis is plus 90 to plus or minus 180. If you look at this zoomed up view and focus on lead 1 and AVF, you see how you could estimate which way the axis is by looking at these two leads. Now, if you consider hemiblocks, you have left anterior fascicular block and left posterior fascicular block. Left anterior fascicular block, the diagnostic criteria are left axis deviation. In leads AVL or lead 1, there's a QR complex. In leads 2, 3, and AVF, there's an RS complex. The QRS duration is less than 120 milliseconds. Here's an example EKG obtained from litfl.com, and this is what left anterior fascicular block looks like. Essentially, a left axis deviation. So, left axis would be minus 90 to minus 180 roughly, and so you would expect negativity in lead 1 and positivity in lead AVF. So here's lead 1. And AVF. So if the electricity is going in that direction, you would get LAFB, left anterior fascicular block. Left posterior fascicular block, on the other hand, is right axis deviation plus 90 to plus 180. And you would expect lead 1 and AVL to have RS complexes, and leads 2, 3, and AVF to have QR complexes. The QRS duration is less than 120 milliseconds. There's an example EKG, and left posterior fascicular block is rare in isolation, and it strongly suggests underlying heart disease. RVH must be excluded. Now, if you have a broad QRS complex more than 120 milliseconds, then you pay attention to leads V1. If there's a dominant S wave in V1 and leads 1, AVL, V5 to V6 show broad, notched, or slurred R waves, this would be a left bundle branch block morphology. On the other hand, if the QRS duration is more than 120, but there's rabbit ears or RSR in lead V1, and leads 1, AVL, V5, V6 have a slurred S wave, that is a right bundle branch block. So left bundle branch block and right bundle branch block. Now, sometimes people have alternating right and left bundle branch blocks. When this happens, this indicates a high degree of conduction system problems. Right bundle branch block itself doesn't change the heart's overall axis. So if someone has a right bundle branch block with left anterior fascicular block, that is a left axis deviation, so they have a QRS duration more than 120, right bundle branch block morphology, and a left axis deviation, that is a right bundle branch with left anterior fascicular block. On the other hand, if they have a right bundle branch block with a right axis deviation, this means left posterior fascicular block, and this indicates extensive conduction system disease. Again, RBB itself doesn't change the heart's overall axis. Now, if you look at group beating, let's say you see a group beating where a few heartbeats happen and then there's a dropped heartbeat, then you should look at the PP intervals. If the PP intervals are progressively shortening and then there's a pause, and the pause is less than twice the preceding PP interval, that's a type 1 SA Wenckebach. On the other hand, if the sudden drop P wave has an exact multiple of the previous PP interval, then there's a second degree SA block type 2. Now, here's a case of alternating bundle branch block I got from the Circulation Journal. So, one heartbeat has right bundle, one heartbeat has left bundle. And whenever you see an alternating bundle branch block, it indicates that conduction system is severely diseased. And the prognosis, this is a very high risk patient and may need a pacemaker. Now, trifascicular block implies a block of all the bundles. So, bifascicular block would be right bundle plus left anterior, or right bundle with left posterior with third degree heart block is a true trifascicular block. And a permanent pacemaker would be indicated. Now, how to diagnose MI in the setting of a right bundle branch block? So, when someone has a right bundle branch block, you would see some STT changes. However, presence of Q waves in RBBB is still valid. So if there's Q waves, that implies a heart attack. Then look for concordant ST elevations. ST changes in the same direction as the QRS vector are highly suspicious for ischemia. Then T inversions in V1 through V4. T inversions are expected in RBBB, but new or disproportionately deep T inversions indicate anterior ischemia. Now, in the case of left bundle branch block, LBBB may obscure a STEMI. For example, you would expect a STEMI to cause ST elevations. However, LBBB may obscure that because of discordant ST changes like we discussed before. So, the specialized diagnostic tool is proposed, and the criteria are called the Sgarbosa criteria. If you have concordant ST elevation more than 1 millimeter in a lead with a positive QRS complex, you get 5 points. This concordant ST depression more than 1 millimeter in any lead V1 through 3, you get 3 points. If there's excessively discordant ST elevation more than 5 millimeters, this is not such a strong criteria, but this gives you 2 points. Any person with more than 3 points could have a STEMI. So, that is Sgarbosa's criteria for diagnosing STEMI. So, you analyze the EKG, look at the QRS duration. The QRS duration is less than 120, check the axis. If it's left axis, that is QR in 1 and AVL, it's a left anterior fascicular block. If it's right axis, that is QR in inferior leads, it's left posterior fascicular block. If the QRS duration is more than 120, check the morphology. RSR in V1 is the right bundle, check axis. If it's left axis, it's right bundle plus left anterior fascicular block. If you have a wide QRS more than 120, you check the morphology. There is left bundle branch block, which is a dominant S in V1, and this is left bundle. On top of this, if we suspect an MI, you apply the criteria like we discussed earlier to diagnose a STEMI. Now, if you review serial EKGs and look at the rhythm, if somebody has alternating right and left bundle branch block morphologies, they are at high risk for complete heart block, consider a pacemaker. If you have group beatings, investigate whether it's SA or AV block. Look at the PP intervals. If the PP intervals are progressively getting shorter before the drop beat, it is a type 1 Wenckebach SA node. If the PP intervals of the drop beat are an exact multiple of the previous PP intervals, it's a type 2 SA block. Then synthesize all the clues. If you have a bifascicular block with a third degree heart block, then a pacemaker is definitely indicated. Thank you for watching. More to follow.